good afternoon, and thank you everyone for this talk. And first of all, thanks to the organizers for giving me this opportunity to talk something about the research. So I represent the Center for Brain Research, and I bring greetings from the Center for Brain Research. Center for Brain Research is about 100 meters in this side of the road, and that's where we are housed in, and that's where our data and the work with respect to neuroscience happens. So without any further ado, let me kind of give you a quick introduction on what I'm going to talk about. I'll be talking about the risk factors as well as the cognitive reserve and resilience factors, especially in the context of Indian population. So we all know that dementia is a neurocognitive disorder and it disrupts the functioning. And the global burden of dementia is gradually increasing. And right now, India is riding on the demographic dividend. But very soon, we will have a population who will be elderly. And with increasing age, there's more likely risk of cognitive impairment. And this number is projected to increase to 139 million by 2050. That's for the global projections. So this is where we stand. And this data is from the blueprint for dementia research by WHO. So if you actually look at this, some of the work we had initially began with is try to look at dementia, especially in the background of a low and middle income country like India. So as of 2023, 153 million people were aged 60 years or older in India. We do not have a census. The latest census was 2011. So because of COVID, we didn't have a census after that. But very soon, I think the number would be triple to that. So we have to see. And most of the elderly are from the southern part of the country. So that's also something which we have to be alarmed of. And to move forward, we may have to look at reducing the burden of dementia, improving the quality of life of the patient. So that should be our focus. And CBR, the Center for Brain Research, the mission statement is to work on aging brain and neurodegeneration and to develop maybe early biomarkers and neurointervention strategies. So we have two cohorts at CBR. So one way to understand aging and aging brain is to look at people who are aging. And that's how we looked at two communities. One is the urban Bangalore. So what does the urban Bangalore look like? It looks like this whole. We are people from different part of the country or the world. So in Bangalore, we have 1,000 people whom we follow up. We do the detailed evaluation, then we follow them up annually. And then we have in rural cohort about 10,000 participants. This is the Srinivaspura Aging Neurosciences and Cognition Study. This is about 100 miles, about 100 kilometers from IISc. So it's about 2.5 hours journey. So this community is chosen very strategically because this would give us an idea about the people there. They have been living there for generations. And the reason is there is less migration. And why is there less migration from Srinivaspura to Bangalore is they actually are the largest exporters of mangoes in the country. About 63 species of or varieties of mangoes grow there. And so these are people who are staying there for decades. They are financially stable and they do not have a need to migrate for newer jobs. So we have on one hand urban population where people are more into tertiary occupation, higher literacy rates, more migration, more multilinguals, more genetic heterogeneity. Whereas the other cohort would be more of agricultural, agrarian, low literacy rates, lesser migration, more mono and bilinguals, and less genetic heterogeneity. So this is the main strategic aspect. Now coming to what all studies we do or assessments we do for the participants, we do a detailed demographic assessment, clinical evaluation, cognitive assessment, blood biochemistry, including LFT, RFT, thyroid profiles, vitamin D, B12, all that, blood biomarker analysis, genetic analysis, brain imaging. So all of them get an imaging, especially from the urban cohort. We also do what is the optical coherence tomography, pulmonary functions, cardiovascular parameters, gait and balance, as well as audiology. And this is done at every, like we get annual follow-up. So this is how it was conceived. That urban cohort started in 2015, and the first 1,000 people were reached by July of 2022. And we have the first follow-up in November of 2023, and we are expecting the third visit to happen next month for the 1,000 people. And the SANSCOG, we have completed recruitment for 10,000 individuals. So what are strategies for reducing burden of dementia? So what I am intending to do here is to present data from what we have obtained. So it would be more of in-house data from Bangalore. So you can be kind of asking me if time is there to permit questions. So what are strategies for reducing burden of dementia? The strategies include early identification using biomarkers, identifying the at-risk or vulnerable groups like ApoE4 genotype, reducing modifiable risk factors of dementia. So that's something which we have been working on tirelessly. Actually, we're trying to look at the modifiable risk factors of dementia. And the Lancet Commission in 2024 has told that 45% of the prevalence of dementia worldwide can be prevented by addressing modifiable risk factors, about 14 modifiable risk factors, all of which we are working upon. Then enhancing protective factors for dementia. Are there something, especially in the Indian context, which are quite unique and protective for cognitive impairment? That's something we want to look at, and improving cognitive resilience. So with this in mind, I'm trying to see the focus, the neurocognitive biomarkers. So we all know about fluid biomarkers. But what about the tests? Are the tests themselves suitable for assessing patients with dementia? We have the mini mental status examination. And there are three objects memory recall is there: apple, table, and penny. Now, can somebody from rural India actually understand what is apple, table, and penny? And then after 3 minutes, for him, it's just a vocabulary kind of exercise rather than understanding the meaning. So then we have to transliterate it and validate it and use it for the Indian population and make normative curves out of it. So that is where this apple, table, and penny, when Dr. Mary Ganguly, who developed the HMSC, or known as the Hindi Mental Status Examination Assessment, converted that into mango, chair, and coin. So that's how it is. We have to maybe transliterate, and this has to happen in different languages. Fortunately for us, the Addenbrook's cognitive examination, that is validated for at least 7 languages, 7 Indian languages. So we try to use the Addenbrook cognitive examination tool and try to see whether the scores from that itself can help the clinician to identify patients with mild cognitive impairment. So we looked at what is known as the verbal language orientation memory scores, which was previously used to distinguish between FTD, frontotemporal dementia, and Alzheimer's dementia, and tried to see we can actually fit that to identify mild cognitive impairment early. So that's something which we have done. Then we also try to look at neuroimaging, because that's one treasure trove we have. And we try to look at hippocampus and amygdala subfield volumes. So people have looked at hippocampal volumes and amygdala volumes for long. But we try to look at the subfield volumes and identified that the CA3 region of the hippocampus, especially the atrophy of that, could be more predictive of mild cognitive impairment, which is a pre-dementia stage, than atrophy in the other places. Also, we try to look at at-risk groups, like people with ApoE4 genotype. The ApoE4 genotype is quite interesting because in the Caucasian data, if you have ApoE4 homozygous trait, you are at least at the odds of about 9 times more to develop dementia than general population. And if you have heterozygous, you are a carrier for ApoE4 status, you have about 3 to 4 times odds. But for Indians, the data is not available. And for Africans, actually having ApoE4 is actually protective for dementia. So it's very interesting how things work around. And ApoE4 actually is more in Africans because it gives them protection against malaria. So these are some things which malarial parasites. So that's something very interesting. We try to look at ApoE4. And what we understood is that the more non-modifiable risk factors like ApoE4 genotype is actually modulated by physical and lifestyle related factors. So it was ApoE4 genotype was not associated with attention function in our cohort, but it interacts with other aspects like age, gender, and education. And as secondary part, it affects the attention. So we try to look at the risk factors. I've told you all the 14 risk factors were there. And if you actually modify these 14 risk factors, you can reduce the prevalence of dementia to less than 45%. So that's something great. You can actually reduce dementia. You can reduce the prevalence of dementia. So we try to look at all the 14 risk factors, and the arrowheads points to the kind of areas or risk factors which we have been working on in our cohort. So there's some cross-sectional data which I will be just trying to show a bird's eye view. Regarding vascular risk factors, just look at the prevalence of hypertension and diabetes in our cohorts. It's about 39.84% and 22.7% in the urban and the rural. So especially if you look at, this is from data from the urban, and you see the hypertension prevalence is more than 35 or almost 40%. And if you look at the insulin resistance, which is one of the important criteria for metabolic syndrome, it is also quite prevalent. We saw people who are at least the prevalence of insulin resistance was more than 50%. So it's more than 1 in 2 have insulin resistance, and they have poor cognitive functions. So that link was also established. The prevalence of metabolic syndrome again was shocking. In rural, it is 46.2%, and it's urban, it's 54.8%. That means if you look at this room, we can see half of us would be going to hell and half may be going to heaven with respect to the cardiovascular risk factors. But our definition of hell and heaven are different. The higher Framingham risk scores, something which we also looked at, shows that the higher the Framingham risk scores are there is lesser scores of attention, memory, language, and visuospatial functioning. There's another important risk factors, often underreported, under-neglected, and not very, very well researched. That's homocysteine. If you actually see the mean homocysteine value of Indians, it is much more than the normal cutoff. The worldwide cutoff is less than 15, whereas for Indians, the mean value in our population was 17.89. And these are cognitively normal people without dementia. So homocysteine levels are quite high in the Indian population. And if you have a homocysteine level more than 10, it increases the risk of stroke for more than 40%. So that's something which we have to be mindful about. And participants with high homocysteine levels were found to have lesser scores in the language domain and lower cerebral white matter volume. So these were some findings from our initial studies. Now, you also looked at something like sleep. Sleep has been widely discussed. We know that sleep is important, but shorter sleep duration was significantly associated with poor performance in delayed recall task. This was for cognitively normal people, cognitively undemented people, people who do not have dementia, and this is what has been observed, that lesser sleep efficiency was significantly associated with poorer delayed recall and semantic association task. So we try to look at all this. Now, we also know that India's capital is slowly becoming the diabetes capital, but Bangalore is also the asthma capital of India. So we try to look at the particulate matter, the pollution related aspects. So PM 2.5, which is the particulate matter 2.5, is associated with poorer cognitive performance. It's well known, but it has to be widely popularized so we understand the impact of this. And in our cohort, we also looked at traumatic brain injury. So traumatic brain injury has been studied in a larger manner, and the performance in implicit memory tasks was affected. Previous studies abroad were showing deficits in explicit memory, but in our cohort, we also understood they have implicit memory deficits as well. Now, looking at education. So till now, I was giving a negative view of things. All the risk factors, diabetes, hypertension, dyslipidemia, you name it, but are Indians also having some inbuilt protective things which we can utilize? Education is increasing, and people who are better educated perform better. It's well known. So that is something which we can actually utilize. And education acts as a protective factor by enhancing the cognitive reserve. Now, Indians, being Indians, we also are at a very good advantage. At least I know all of us would speak 2 to 3 languages. Some 10% would be able to handle 5 languages and more. So if you actually look at it, that's something which is a strength for our population. So higher rates of bilingualism or multilingualism is protective. So that's something quite interesting. And multilingualism we have studied in both our cohorts, but in the rural cohort which has been published, we have identified that multilinguals had lesser odds of developing mild cognitive impairment compared to monolinguals. So that was a very interesting finding, and this could give us a clear example that if you're multilingual, less chances of you belonging to in the mild cognitive impairment group. We also try to look at physical activity. Definitely there is a lot of evidence. The LASI data has already given some evidence that higher engagement in physical activity is associated with better cognitive functioning. But it also encourages social engagement. So physical activity also increases social engagement, social connectedness, which are also protective. And individuals involved in regular physical activity have better global cognition and better memory. So this is some initial work that we have done. Now, what about music? Now, India is a land rich with music. Every state, every place has its own musical heritage. And we try to look at music and Carnatic music, especially vocalists. We try to look only at vocalists so that we don't get any differences there. And we found out that they had higher gray matter volumes in musicians compared to non-musician counterparts. So that's something very interesting. But they had a smaller cerebellum. So is smaller cerebellum good? Yes. If you acquire music quite early, you can have metaplastic changes in the cerebellum. And that is actually quite beneficial and shows that amount of functional connectivity that you are having. We also looked at social connectedness and understood that it's the network diversity which has significant roles to actually improve cognition. People who are more socially connected have better cognition. So if you can look at the performance in the ACE total with respect to attention and also more with respect to the gray matter and white matter volume. This was published last year to end of last year and we have understood that definitely social connectedness improves the gray matter as well. So promoting cognitive resilience, which refers to the ability to resist pathology and preserve cognitive functions, is something which has to be researched in a great deal. And the factors boosting cognitive resilience will be analyzed subsequently in a more longitudinal fashion. That's what we are planning to do. And we also want to follow people who are successful agers. There's a concept called super aging. And we want to try to look at people who are successfully aging and see some of their determinants which could actually protect them against developing any other problems or any other issues associated with frailty and aging. For this, we have also partnered with the Worldwide Fingers Initiative, which is the worldwide Finland-based intervention. Finnish intervention to reduce geriatric cognitive impairment and disability. So we are part of the Worldwide Fingers, and we have initiated this trial. Actually, this pilot study got over last month, and we are in the stages of analyzing the data. So actually, we had looked at multimodal lifestyle interventions, A, B, C, D, and E, where A stands for control of vascular risk factors, and B for being aware or mindfulness strategies, cognitive training, dietary modifications, as well as exercise. And that is something which we have been doing. Now, if you actually follow the Fingers protocol, you are supposed to follow what is known as the Mediterranean diet or the Nordic diet, where you actually give you have to take salmon fish, you have to take olive oil. Now, how can you explain that to somebody in rural Srinivaspura or for Bangalore also? Can you kindly start eating salmon fish and let us also start using olive oil instead of mustard oil or coconut oil, especially from Kerala, it's a taboo. So that's a challenge. So we had to tailor it based on their requirements, and we try to look at their daily dietary requirements based on the ICMR NIN guidelines, and then we adjusted. So no vegetarian person had to become non-vegetarian, but based on their lifestyle, they had to ensure that they have to take adequate amount of calories, proteins, and dietary fiber. So with which, along with that, you cannot ask aerobic exercises to be done in elderly, which was there in the Finnish group. So we adapted that and asked them to do more of walking as well as certain yoga practices. And yoga practices alone will not help. So we gave them pranayama-based techniques as well as basic stretching kind of yoga. So about 120 people actually completed this very nicely. And we understood that the results are very promising. This is not a big study. It's only 1 year study, and found that they had significantly improved. I think these aspects are something which are going to encourage people like us, and I thank you all for your attention. Thank you.
So we have time for a couple of questions.
Dr. Isaac, I'm Dr. Shabnam Kar. I'm a functional medicine doctor. My area is dementia prevention. So, number one, I missed, I think, what is the age group you're looking at?
Yeah,
What is the age group?
45 years and above.
Okay, because we know that dementias like Alzheimer's start about 20 to 30 years before.
Yes,
So, you are going to follow them over?
yes.
Okay. The second question I had was about the bilingualism and multilingualism. So, did it matter how much proficiency they had in each language? Like, were they able to read, write, and speak?
Yeah.
Or was it only speak many languages and read and write only a few?
Yeah, yes. So that's a very good question, ma'am. Thank you for that. Just to kind of not take much time for the next speaker. So the data I showed is from the rural cohort, where most of them were illiterates. Okay. And they could only handle language by talking. So these were people who could handle, because Srinaspura also comes in the border to Andhra. They speak Telugu as well as Kannada. So these are people who were, the literacy rates, somewhere actually the years of schooling average was about 4 years. So these were people, even without any education, they were able to actually reduce their risk for developing mild cognitive impairment.
That is very good news for us, because many of us can speak many languages, not write and read.
One more question.
Hi. So specifically on your slide on music,
Yes.
I just wanted to understand, especially with Indians, there are a lot of complex, uh, traditional behavior like Carnatic music, like Vedas,
Right.
and a lot of that
Yes.
lot of that is very complex and pretty musical. Have you
Yes.
studied any of that?
So
And
that's
is there
something which is close to heart. We want to study. We want to also look at people who do instruments, mridangam and all that at very young age. I think the author of that paper is sitting next to you. Maybe you can catch up sometime. So this is something which we want to actually look at and study, especially the practices, even the religious and spiritual practices, which may have lot of features giving, contributing to cognitive reserve. So that's something which you intend to do. Yeah.
And just, I'll take 2 more seconds because this is just coming from observation from our earlier generations. They didn't necessarily follow a high protein, low carb diet or exercise, but just the routine of
Yes.
religiosity in their lives with
Yes.
that impacted them quite a bit positively.
Absolutely. Yeah.
So I have a question. I'm just a beginner. First year MD I'm pursuing. So your cohorts, they had 10,000 and 1,000.
Yes.
Will there be any difference because there are such a huge difference?
Yes, yes, there's a difference. We may have to adjust for all of that. We may have to take, so most of the studies we have take matching for education, age and gender. So we have tried to keep that much as possible. If you look at our papers, we have not compared 1,000 with 10,000, or we have done regression to adjust for that. I think we have to respect the time, I feel.
Then the next speaker will get cut short. Okay.
Thank you.
You can take it offline.